We now look at thromboembolism, a continuation of what we've just talked about. The pathophysiology, endothelial injury from traumatic delivery or cesarean, vascular stasis, and increased clotting factors. And when you look at the Virchow triad for blood clotting, this is it. Endothelial injury, vascular stasis, increased clotting factors, and these are all more likely in pregnancy. Now, the endothelial injury, postpartum, because of delivery, because of cesarean section. Vascular stasis is, of course, always an issue during pregnancy because we have a decrease in venous flow in the lower extremities during pregnancy. And the clotting factors take many weeks, if not months, to reverse after pregnancy. If a patient has coagulation protein deficiencies, that in addition to these others can cause thromboembolic disease. And we already talked about this in our section on thrombophilias. Now, superficial thrombophlebitis does not predispose to thromboembolism. It does not connect with the deep veins. Symptoms include localized pain sensitivity. There may be erythema tenderness. What you want to do here is to get a duplex Doppler. Make sure there isn't any DVT. If there's no DVT, our diagnosis is one of exclusion, superficial thrombophlebitis, and this is managed conservatively. Bed rest, local heat, anti-inflammatories, no need for heparin. Deep venous thrombosis, different story. This does predispose to pulmonary embolism, and in pregnancy, the site of thrombosis is typically in the lower half of the body, half the cases in the pelvic veins, and half in the lower extremities. Now, the diagnosis of deep venous thrombosis in the pelvic veins is very difficult because you have no easy way of assessing that. In the lower extremities, it's much better. Symptoms, pain, increased sensitivity, but by far the majority of patients with deep venous thrombosis have no complaints at all. It is silent. Calf pain may be present, but the absence of a Hohmann sign, pain on dorsiflexion of the foot, does not rule out DVT. The diagnosis is by duplex Doppler. Now, below the knee venography is helpful, but when you have the slow flow in pregnancy and the dilated veins, the contrast is very poorly seen above the knee. Duplex Doppler is really the way to go. Management. If she has deep venous thrombosis in pregnancy, we need full anticoagulation. You will get a PTT, and we want to increase that baseline level to 1.5 to 2.5 times what the control was. Once you've obtained adequate anticoagulation with the intravenous, then you can switch over to subcutaneous heparin. And if you're using unfractionated heparin, we'll give up to 30,000 units a day. If you're using the low molecular weight, then you will adjust according to your anti-10A level. We do not use the oral anticoagulants because of teratogenicity concerns. Probably the most severe of the thromboembolic sequelae is pulmonary embolism. This is a potentially fatal result in which emboli travel through the venous system to the lungs, and if they completely occlude the pulmonary circulation, you have a saddle embolus and sudden death. The source of most emboli, as we said, is in the lower extremities of the pelvis. Symptoms include chest pain and dyspnea. Most patients will have chest pain and dyspnea, but when you look at some of the other findings, chest x-ray is often normal. Arterial blood gases may be in the normal range. EKG is also normal. So one has to have a very high threshold of suspicion. The preferred diagnostic method is a ventilation perfusion scan, a VQ scan. You're going to get results either positive, negative, or indeterminate. If it is indeterminate and you're not sure, that's really the only indication for pulmonary angiography. Management. Full anticoagulation with intravenous heparin, similar to what you do with deep venous thrombosis. You want to increase the PTT by 1.5 to 2.5 the control value. And again, we don't use any oral anticoagulants because of concern about teratogenicity. All right, let's look at a few high-yield questions. 34-year-old gravida 3 para tube. Patient has unilateral right lower extremity swelling, redness, and tenderness. What's the best method of assessing deep venous thrombosis? And we just talked about that. Duplex Doppler would be the way to go. Duplex Doppler. Okay, we got a duplex Doppler, and the Doppler shows that she's got deep venous thrombosis. Management: heparin, Coumadin, aspirin, NSAIDs, IV heparin. During the pregnancy, IV heparin. After the pregnancy, we can go to Coumadin. When during pregnancy is the likelihood highest for deep venous thrombosis? And we already talked about this as well. The postpartum period. So any patient who has a significant risk factor, even if she's not treated antepartum, should be treated for 6 to 8 weeks postpartum. Okay, this has nothing to do with thromboembolism, nothing to do with thrombophilias, but I wanted to get it in some place. What should you do in terms of seat belts for pregnant women? Pregnant woman inquires whether she should wear a seat belt. What do you think? And the data from the California Highway Patrol is very clear that babies don't do well whether the mother wears a seat belt or not. But the mom will do much better if she wears a seat belt. The lap belt should be worn low. Shoulder restraint is appropriate. And that is the end of our section on thromboembolism.